don't see a whole bunch of loiterers outside, so I'm going to go ahead and start to introduce Jarod Hall. I made it big so I could see it, but then it wouldn't fit. Okay. So Jarod Hall is a physical therapist from Fort Worth, Texas. His clinical focus is orthopedics with an emphasis implementation of an emphasis on the current pain science of pain, to aid in the management of both chronic and acute injuries. Jarod has shown clinical excellence in securing designation as a board-certified orthopedic clinical specialist and certified strength and conditioning specialist. He is lab faculty at UNTHSC DPT program. You can tell us what all the letters mean later. Okay. Instructing in conditioning and manual therapy. Jarod regularly presents continuing education at the state, national, and international level for practicing physical therapists, occupational therapists, and chiropractors. In addition, Jarod developed and leads both an orthopedic board specialty examination preparatory course through the Optum Manual Therapy and Fellowship, as well as a virtual mentorship with Modern Pain Care for practicing physical therapists seeking to further their clinical expertise. He is author of the clinical resource text, Sticks and Stone, a collection of analogies and stories to better understand pain. So I'd like to welcome to the stage, Jarod Hall.
So I realized in listening to that I need to rewrite my bio because it's terrible. The UNTHSC is the University of North Texas Health and Science Center. What I have learned so far this weekend is that about 60% of my presentation has already been given. So just kick back, relax, don't try to stress too hard. Everything that I'm going to say has pretty much been said already and more eloquently. And in fact, Eric last night brought the heat and used about 7 of my slides, like identical slides, like over illusions. I was like, no, I'm done. But he did it really well. So I woke up at 4:30 this morning to pull those slides out, switch some stuff around. So I'm just like totally winging this presentation. It's a little bit different. I'm still going to talk about some of this stuff. I'm still going to refer to it, but hopefully I can focus a little bit more on the clinical implementation side of things. We've covered just like a tremendous amount of information. We've had some great presentations so far this weekend, but I want to see if we can actually like make it a little bit more simple at the end and give you something that you can take to clinic on Monday. You can challenge yourself to be better with. So. Who am I? I'm not that dude in the bio because that guy sounds terrible. In reality, all right, Nick is going to laugh for like 20 minutes. It's going to happen. So I'm from Texas. I like to play golf. I'm a partner in Modern Pain Care. I really like to read and philosophize a ton. And as you have probably seen this weekend, I like to drink way too much when I get with friends. And I'm struggling right now, so bear with me, all right? But when I'm not doing those things, really what I do is focus on spending time with my wife. We like to cook a lot of food. We like to enjoy time with each other traveling around the world. So that's my big focus right now because I'm young, I'm married, and I don't have kids. So that's me in real life. That's not me in a bio. So why am I here? Hell if I know. I just really asked Rajam nicely, and she's like, you know what, we had 17 people drop off the ballot, so I'll let you come speak. But since I'm here, let's talk about some pain-related stuff, because that's how I feel when I get to talk about the pain-related stuff. It's my nerd factor. I love it. I get zoned in, and I really drive my wife and my friends crazy who are not physios. So let's look quickly back at the past. This has been touched on a couple of times this weekend, right? This whole biomedical thing. We used to have a lot of bottoms-up theories that we used to treat people. The standard, biomedical model is largely based on the passive stimulus-driven thought process that 1 unit of pain equals 1 unit of tissue damage, and that what happened in the periphery is exactly what somebody would feel, right? Functions under the notion that the brain just receives information and it's just automatically the experience. So that's the Cartesian model, right? So it implies that pain results from body parts wearing out and is a direct representation of what's going on in the periphery. We've talked extensively about that this weekend. And it makes me think that everybody is just, really small-brained. But there's problems. So there's no explanation for the experience of symptoms without any clear pathophysiologic disruption. There's a discordance between experienced pain and the degree of tissue damage. There's no explanation for the experience of relief following an inert treatment that maybe is positively primed or has expectations associated with it, or the negative outcome as a result of negative priming or negative expectations. And it does not at all reference anything about the social system. It doesn't reference anything about psychology. It doesn't even give a hat tip to contextual influences. But more recently, we've started recognizing top-down processing. And I'm going to do this because I'm like Dr. Evil, like processing. And because I don't really know if the brain processes. We were having a nice discussion earlier today with some people that are a lot smarter than me, Corey and Todd and several other people, talking about the computational model of the brain and, if it is something that's constantly actually like running mathematical algorithms to figure out what consciousness is and generate our experiences and that sort of thing. So I'm gonna say processing because I think that it's a good proxy, but I don't know that that's exactly how it works. But we're starting to recognize that our surroundings and our environment play a role in what we experience. Our expectations play a role. Our prior life experiences play a role, our associative learning, our beliefs, our cultural factors, current emotional status, all this sort of stuff plays a role in what it is that we come to experience, right? So it's a nice shift forward. But let's look at the future a little bit. So I think that not only do we have to recognize top-down, but we also have to recognize bottom-up. We can't forget everything that biomedicine has taught us that has been effective, that has been helpful. We need to pair that with what we're learning about top-down issues, but then we need to also add in the fact that the environment is coming into us from multiple different directions, and we are acting out upon the environment as well. So there's this bidirectional or multi-directional relationship between top-down, bottoms-up, the environment, and how we actually live and interact with the environment. So that's a little maybe hat tip to that inactivism type approach that Corey talked about yesterday from Peter Stilwell and Catherine Harmon's paper that was published this past year. But what this kind of leads into is that computational model or that processing model that perception of reality may be a prediction of sorts that arises through almost instantaneous and simultaneous evaluation of all incoming sensory information. So I am purposefully underlining and bolding qualifiers that say I don't have a frickin' clue. This is my opinion, and this may or may not be right, and in fact, it's probably not right because every theory that we've ever come up with about how the human consciousness comes to be and what pain is has been proven wrong, right? So we're just constantly trying to become less wrong. And what that's a hat tip to is what's called the pessimistic meta-induction of knowledge. So show of hands, who's heard of the pessimistic meta-induction of knowledge? All right, boom, in the back. So what that is the concept that just about everything that we've ever known, we've come to know that we don't actually know it and we were wrong, right? So think about all the theories of different pathologies that we've had. Think about all the theories we've had about how things work, and over time, we actually find out that we weren't as right as we thought we were. So we have to be humble enough to recognize that what we know right now is probably not right and will probably be proven wrong in the coming years. We have to be humble enough to say, I believe this now and this helps me function in clinic now, this helps me work with people now, but I also need to be able to drop away from that, not be too tied to that, and update my ideas as new information comes out, right? So that's basically the definition of evidence-based practice, being able to continually challenge yourself and not hold too tightly to any one belief about the absolutism of how something works. So these predictions, they arise out of evaluation of all incoming sensory information, monitoring of the environment, consideration of prior experiences, weighing current expectations, and then that bidirectional interaction that I was talking about with society, with culture, with our environment, all this sort of stuff. So this idea, like I said, is called predictive processing. It's, without getting into the mathematical aspect of it, it's called a Bayesian approach to perception. And Bayesian modeling is like this really complex math thing that I don't understand, where there's crazy algorithms, that are trying to figure out what probabilities are and what's the likelihood of something happening, and constantly updating those probabilities based on all the incoming information that you're getting, based on all the new things that you come across, based on new stimuli, based on new information. So this concept of predictive processing suggests that in order to perceive the world, the brain functions similar to a computer. And I think that all of us in here would probably feel a little bit concerned with saying, oh yeah, the brain is a computer. But when we interact with people, when we work with people in our clinic, metaphors are powerful. That's been alluded to already, right? Metaphors are powerful, and we need to educate people in a way that they understand. And we're restricted by the language that we have in how we communicate things. So we can only do as good as what the words that we know and the concepts that we have can apply to a topic. So we're going to say that, maybe this computational model isn't right, but it ain't all that bad for helping a person that is experiencing pain understand that there's a lot of complex things going on. So the Bayes theorem, it's the mathematical thing. It's essentially constantly asking, how likely is this going to be, right? What is the likelihood of X, Y, and Z happening? And I'm going to take all the sensory information that's coming in, I'm going to weigh that with all of my prior experiences, and I'm going to make my best judgment guess about what's going to happen, what I predict will be my reality in a millisecond, in a split second. So what does that actually mean? It means that we're always generating hypotheses about what we are experiencing or what we're about to experience. Top-down flow of hypotheses are met by bottom-up sensory information. That sensory information may not match with our predictions or with our hypotheses. And when we have sensory information that doesn't match with our hypotheses, what we do is we make an update to our predictions, because that's a prediction error. They don't seem to line up with each other. So I think this is gonna hurt, actually that wasn't so bad. So now I've learned about whatever it is, or I don't think that this is gonna hurt, like a young child sticking their hand on the stove. They have no understanding that that's gonna be painful, or that could potentially damage them. It happens one time, they learn it, it's a new prior experience, and now anytime there's stoves around, I'm gonna predict that potentially this could be painful if I stick my hand on it. And if I'm met with some sort of sensory stimuli, even if it's not necessarily a highly dangerous stimuli, I may predict that I'm in danger because it's close enough that it reflects what I think is going to happen. So a central implication of this theory is that what we perceive is not the world as it actually is objectively, but it's our brain, our minds. I don't like just using the word brain. Our mind is maybe a little bit bigger than just our brain. It's our best guess of it. And Eric talked about this a lot. He referenced Anil Seth's TED Talk on the whole concept of hallucinating reality. And the first time I came in and read about this, it absolutely just like blew my mind up. And that was a couple of years ago. I'm still trying to wrap my head around everything, and that's the conversation that Corey and Todd and Marcos and I had earlier in the day, is that I'm struggling to wrap my head around biopsychosocial versus inactivism versus predictive processing. And at the end of the day, Todd broke it down, and he just said, it's probably all of these, it's probably none of these, but it's probably all of these, it's probably none of these, and maybe it actually doesn't really matter except for in highly specialized scientific research, philosophical discussions. But what does matter is that we can take these concepts, we can bring them into the clinic, we can make them relevant for people, we can help to update their perceptions of what's going on in their life so we can reduce their fear. we can reduce their anxiety, we can get them actively encouraged and engaged in moving forward in a way that is different than just a passive approach, in a way that thinks that they need to be fixed, in a way that perceives that they're broken, right? So that's what this is really all about. Whether it's a model, whether it's a framework, whether it's a theory, that's just cool stuff to talk about, but let's get real with it. So for me, this is an example of predictive processing as simple as I can think of it. You got a big elephant, and you got a little hippo, and you got a little turtle balancing on there. It's like a Jermit. Was that correct? Kermit with a J, Jermit? Yeah, like the frog, turtle, reptilian, amphibian. So, as simple as I can, when priors are more heavily weighted, they may dominate a prediction, which dominates the subsequent experience. But if sensory input is more heavily weighted, it may dominate the prediction and the subsequent experience. And we're never going to be able to ferret out which one is more dominant. But we just have to recognize that sometimes the experience that we have doesn't match up with the sensory information coming in. And that our prior expectations of that experience don't match up with the sensory information that we end up experiencing. So, do we live in a subjective hallucination? Is this the Matrix? Because I'm freaking out, man. But, with two T's, we do have to recognize that this whole concept of predictive processing and activism, and it's not the next coming of Jesus. Or Joletta. Where's Joletta? Hand up. Jesus. Where is Joletta? But I'm going to steal from George Box, and I'm going to say that all models are wrong, but some are useful. And to echo what Todd said earlier, I think that this is useful to talk about. I think that this is a useful concept to bring into the clinic. So let's bring this concept into real life. And this is where Eric stole all of my slides. So yeah. So I literally had to look up new stuff this morning, take out slides, like, oh, he's already used that, they've already seen that. They're not going to be optically illusidized again. So, but he didn't use this one. Yeah, who's seen this one? Yeah, what is it? I heard rabbit, duck, seagull, skunk, and platypus. Okay, what does it look like now? Right, context changes the perception. It's really difficult to see the rabbit now that you hear the quack. But if we flip it, then all of a sudden Bugs Bunny is chilling. He's like, what's up, Doc? And now it's really difficult to see the duck when it's framed, when the same sensory information is coming in with a different contextual expectation, right? So who's seen this one? Wait. Who sees the soldier? Show of hands. Who sees the dude mooning you right now? Yeah? So is this where the term asshat came from? That's what I think. Okay. What I want you to do is rearrange these letters to form words. Did you guys get spine and subtext? You dirty bastards. No, I got the same thing. I'm totally sick. So we talked about the rubber hand illusion yesterday, so I'm not going to go into that. But who likes Skittles? One person in this room likes Skittles? Seriously? Did you know that all Skittles are the exact same flavor? They just have a different color and a different scent? Yeah, I just ruined Skittles for you. Yeah. So they use scent, they don't use flavor. All Skittles are exactly the same. And most gummy bears are the same too. Yeah, I ruined your candy life. So what about context? Rather than physical illusions and optical illusions, let's look at contextual illusions. Who in here rides a motorbike? Anybody? Or a bicycle? Yeah? Did you know that there is way, way, way more accidents for motorcycles that are called look but did not see, right? This is what happens, and it's called inattentional blindness. And that means that you are expecting to see a car when you pull up to an intersection and you look left and right, because you've been primed to see cars, because cars are way more frequent. You're looking for two headlights, you're looking for a certain size, you're looking for a specific object. And what most people who get in look but don't see accidents report is that they never ever saw the motorcycle that they turned right out in front of and hit. And every single time the motorcyclist says, I looked you dead in the eye and you ran me over, right? So how can you not see something that's there even when you look for it? Because you're expecting to see a car, and when your prior expectation doesn't match the sensory information coming into the system, your prediction doesn't match up with objective reality. So we got a little video here. You guys might have seen it before. Show of hands who's seen it. All right. Do you think this could scar somebody, like totally mess up their mind? Does that sound like real fear?
So after watching,
So, show of hands, who thinks that those people were really scared? Yeah? Who thinks that they had an increase in heart rate? Yeah? Who thinks that their respiratory rate increased? Who thinks that they dropped some adrenaline in the bloodstream? Who thinks that they dropped some neurotransmitters like crazy and got some cortisol going? Who thinks that their bowel and bladder system shut down a little bit and they got a little bit of sympathetic going on? Yeah? So were they really actually in danger? Objectively? Folded up pieces of paper and a little blunt plastic object poking them? Did it seem like some of them actually had pain with some of that? Did it seem like they were really responding aggressively to it? Yeah. So this is prior predictions based on my understanding from a cultural perspective of what a beekeeper is and what bees do. And now I'm trapped in a space with the bees, and I think that they're gonna sting the shit out of me. So I freak out, right? So could you imagine, from a different perspective, people that we work with who have certain perceptions about what their reality is, certain prior beliefs, and they think that movement is going to be painful, or they think that X, Y, and Z is going to be painful from their experience with their family, their experience with culture, their experience with TV, their experience with prior medical providers, their experience with all of these things. Now, they have a system that is primed to maybe respond quite aggressively to relatively benign or not super dangerous sensory stimuli that's coming in. Does that seem reasonable? Yeah? Okay. So what does it really mean? It means that perceptions may potentially influence pain, or if not pain itself, fear and anxiety, right? So you have the exact same noxious stimuli coming in here. On the left side, it's coming into somebody that's saying, shit, shit, shit. Oh, shit, guys, this is going to hurt, right? So that's a reference to this video back like 15 years ago on YouTube. It's called The End of the World. Look it up. Over here on the right, you got Hakuna Matata, this won't be that bad. So you have the same noxious stimuli coming in, but you get a different weighting of what your reality is. And that might lead to a different experience. And that experience could shift one way or the other based on all of the things that are going on, right? So let's look at another hypothetical scenario. Over here on the left, we have the vacuum. We have biomedical land over here where we think that 1 unit of tissue damage equals 1 unit of pain. And on the right, we have real life. So somebody gets a little stub on their toe and just totally different experience from the same noxious stimuli, right? You've got on the left in the vacuum what most medical providers and what most people think is that my pain is your pain because we had the same tissue damage. We had the same sensory stimuli. And what this does is this leads to invalidation of people's pain. So Joe and Keith talked extensively about validation of your experience. And traditionally, we've been number one. We've been scenario one in the way that we look at people. And we need to be scenario two because people have real life issues going on. They have genetic factors. They have associative learning. They have adverse childhood experiences. The keynote, Melanie talked about what goes on when you're a kid directly affects what you grow up to experience, right? So we've got all of this stuff going on in people's lives that are influencing the way that they come to live out an experience. And if we're on the left side, we are invalidating that. We are not believing them, and that is unacceptable. So we have to change that. So where do we actually fit in? What's the real life perspective on this? I'm just stealing stuff from Corey left and right. So it's our job to facilitate the context for healing. And Corey Blickenstaff coined a term, I think he coined it, he can correct me if I'm wrong, called being a contextual architect. So you want to make sure that you are purposefully and being purposeful and being aware of the way that you interact with people to set a context for maximizing somebody's outcomes or maximizing their experience in a positive way. To reference John Quintner, this occurs in the intersubjective third space. So the intersubjective third space is what exists within the environment, society, and culture between a patient and a clinician. So this is where we live. This is where clinical practice happens, in that intersubjective third space. And what I bring to that encounter is biased, and it influences the patient, and it influences what I think. And with the patient, the person, the client, whatever word that we need to put right there to satisfy the appropriate language, brings their own background. They bring their own perceptions. They bring their own beliefs. And then what happens is we intermix in there, and we exist within the environment and between the two of us. So Ben referenced two-person healthcare earlier. So you can see that everything that I'm saying has already been said. I'm just trying to say it different. So what exists in the third space? Red card opinion, right? Let's keep that theme going. I think that communication, it is just communication. And it's verbal, nonverbal, and environmental communication, right? So let's look at verbal communication and how that can influence people within that intersubjective third space. So we got a little Ben Darlow hat tip here. Hard to heal, or easy to harm, hard to heal. You know, what language are we using with people? Are we throwing fuel on their fire? Or are we helping to kind of lessen that fire, cut off the oxygen to that fire just a little bit? Maybe validate them, maybe help to reframe their beliefs just a little bit. We know from pretty decent research that's accumulating that the way that we interact with somebody and the words that we use can actually affect how much pain and how much disability that they come to experience. And this is really, really important to know, and it should light a fire underneath your butt to watch the words that you use when you're talking with people. Sorry, Ben, I didn't say ass. I saw you laughing back there. So this is an adaptation from Mike Stewart, 2018, JOSPT, Sticks and Stones. You guys heard in the bio that I wrote a book called Sticks and Stones, and I want to say I published that before Mike Stewart published this article. So we're gonna bring that up. We're gonna call him out on it. I think he totally stole my words. Probably not. So we got words to avoid, and we've got words to replace those words to avoid with. And this is just a really simple, easy checklist or list that you can run through, and you don't have to use these exact words. And this list is like a laundry list. It can be exponentially longer than this, but it's to start thinking about what can this language potentially mean to the person that I'm talking to. And each individual person that you're talking to could have a different perception of that language. So it might be worth having a discussion with them about how they like to refer to themselves and their body and their injury and their pain and their experience. So I would say, as a physio myself, and probably most massage therapists, probably most personal trainers, probably most physicians that are in the audience, PAs, we've traditionally had a tendency to tell everybody that they suck. We've had a tendency to tell them everything that's wrong with them. So this is circling back around to what Joletta was talking about earlier, right? We have a tendency to tell people that they're doing great for their expired 90-day warranty. We highlight limitations, we highlight weaknesses, we highlight abnormalities, we highlight anatomic variances, we highlight poor postures, we highlight bad movements, we highlight everything under the sun. So patients can feel damn lucky they found us so we can fix them, right? So this is all about providers. This is not about the patient. This is all about us being able to fix stuff. It's all about us being able to find stuff, and it's all about us showing how smart we are when we tell them everything that's wrong with them, because we've diagnosed all of their maladies. But I'm gonna challenge you to actually focus on what's right with people and stop focusing on what's wrong with people. Challenge yourself to employ empowerment and coaching instead of dependence and being a healer, right? All of us want to be a healer. Like literally every PT student that I've ever interviewed says, well, I got into this because I want to help people. That's like the standard answer. Yeah, we want to heal people. We want to like crack that and shift that back into place and needle that and scrape that and like fix it because it's broken, right? That's what we're taught. That's what feels good, because it feels good to be the guy or the gal that does the thing that fixes the person and gets them better. But I'm going to challenge you to tell your patients all of the good factors that they have, all of the things that are making their prognosis more positive, all of the things that are going to help them navigate their experience and their situation to help them get better. So maybe try highlighting if they have physical strengths that'll help them progress well, right? Maybe reiterate that their body is strong and resilient and adaptable. Maybe tell them that you've had experience working with people really similar to them, because human beings love anecdotes and stories. And most people glaze over when you show them research and statistics, unless you're Lars. He loves it. But you got to know your audience, right? So I know my audience with Lars, and I'm going to talk to him about concrete, hard facts and what the research says and what we know if we're having that discussion. But with somebody else, I might paint a picture. I might weave a story in there. I might speak to them in language that's relevant for them. So you might have the conversation about wrinkles on the inside if a person's open to it. I am guilty of forcing that conversation on people, and that does not work out well. But if you can build a relationship with somebody and allow that conversation to come up organically, and they ask you for information. Who was here in the motivational interviewing course? Yeah, did you learn some skills that might help you get to this conversation? Quote unquote through the back door, rather than just boom, 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 like right at you, just vomiting information all over somebody. So it's always with the caveat when and if somebody is ready to hear it. So it's about encouraging a commitment, and encouraging a commitment plan to re-engage in life despite pain, because they're safe to do so. So this goes back around to the living well with chronic pain. This goes back around to Bronnie's information. This goes back around to the concept of acceptance and commitment therapies. And it goes back around to a lot of the things that you heard from Joe and Keith as well. Learning how to live well despite the fact that they have pain. Because pain isn't the thing anymore. It's fear, it's anxiety, it's disability, it's inability to engage with the life that they want to live. It's the loss of the sense of self. So maybe you have to switch it, flip it a little bit. So I'm going to challenge you to be a hope dealer and not a guru healer, right? Joe was talking about this a lot earlier, about providing hope for people. And it's really, really easy to just fall in line with everybody and be the guru healer. But what we're doing is walking people off a cliff. And yeah, it's a little bit harder to go this high road or this long road, this curvy road up the mountain, but it's where the evidence is saying we need to be, and it's where the people who have been through that life experience are telling us we need to go, right? When we listen to them, when we read the actual qualitative data on it. So let's talk a little bit about nonverbal communication. So that was a lot on verbal. So you guys' body language is showing me that you've lost interest, right? It's after lunch, it's the last day, you probably had a beer at lunch. If not, you stayed up way too late last night and had too many beers last night like me. But body language tells somebody a lot. It tells somebody how much you're engaging with them. Jamie, again, stole something from me, golly. We're talking about Peter O'Sullivan's concept of, sitting, it's not even Peter O'Sullivan's, it goes back further than that, sitting on an equal playing field or lower than somebody so the person telling their story can feel empowered to do so and not feel like it's a patriarchal, I'm higher than you type of situation where I'm sitting above you, I'm positioning myself here because it's very paternal and that sort of thing, rather than, hey man, we're equal. We're in this together. This is that intersubjective third space, and let's sit here and figure this out with a joint plan, with shared decision making. Red card. I believe that manual therapy is just nonverbal communication. That's all it is. It's the elicitation of sensory stimuli into the system nonverbally, right? So you're communicating with somebody by the way that you do manual therapy. Are you just crushing them because they think that they're adhered and they think that they're stuck and they think that all of these things need to be fixed because they're broken in there? Or are you taking a different perspective that is trying to meet your pressure and your style and your approach to what it is maybe that person expects or what it is that person tells you helps them feel and move better? So I think that, in my opinion, manual therapy, we could have a debate on that all day long, is really at the heart of things just nonverbal communication. So in that line of thinking, I want to share with you a few of my favorite manual therapies. Fist bumps. When in your life have you ever gotten a fist bump in a negative context? Hey man, I'm glad your grandmother died. Fist bump. Way to fail that, or way to fail that test. Fist bump. Oh, you got in a car wreck? Fist bump. You have cancer? Fist bump. No, you never get a fist bump in a negative situation, but when do you get fist bumps? Way to excel, boom. Way to pass that test, boom. Way to do something good, boom. What does that do? All of a sudden, fist bumps are wired into the brain to spit out dopamine every time you've got a fist bump, right? This is associative learning. This is Pavlov and his dog. This is causing all sorts of neurotransmitters to pop out. This is called all sorts of endorphins and feel-goods to pop out when you hit somebody with the fist bump, because they've learned through thousands of experiences in their life that fist bumps are good, right? What about side hugs? Amy, where you at? Side hugs. We had a conversation about side hugs the other night. I'm a hugger. I'm from the South. When I have a relationship with a patient and it's more than like a visit or two, I have no problem showing them that I care about them, showing them that I value their ability to get better and what's going on in their life past just being my patient. And I'm okay showing a little bit of, actual physical contact with that person if they're okay with it and if it's appropriate at the time. High fives, the exact same thing as fist bumps. Who has ever said, your dog died? Like, no, it doesn't happen. But you hit a home run, high five. You got married, had something great, you get high fives, you get hugs. You get these things that groove in really positive learned responses. So when you walk into my clinic, there are fist bumps and there are high fives happening all the time. Somebody does something that they haven't done before, I'm going to affirm that. I'm going to point it out. I'm going to reflect on that. I'm going to fist bump them. I'm going to high five them, because inside the walls that I work with them in, I want it to be nothing but positive context, in every way possible positive context. Same thing with the back pats. So let's talk about environmental communication. A person's care isn't just what happens once they get inside your clinic and you put your hands on them or you start engaging them in exercise. It's the entire life cycle of their care. It's from what the physician that referred them to you said. It's from what they've heard about your clinic. It's the marketing on your website. It's who makes that first call or who answers the first call to them. How do they manage that situation? How do they set that patient up for success when they walk through the door? How do they prime them to have a positive expectation of their experience within your clinic, right? It's how your front office person interacts with them. Are they caring? Are they open? Are they positive? Are they empathetic? Or are they cold and closed off and, not engaging with that person? Do they ask them their story? Do they actually start triaging information on that first call for you? So you already know what's coming, what Miss Jones is coming through the door with, right? It's how your clinic is decorated. Is it osteoarthritis posters everywhere and disc bulges? Or is it something that's a little bit more empowering and positive? It's all of this stuff. It's your support staff. If you have technicians that work with you, the technicians in my clinic know that they are part of a person's care. And if I can't be talking with the person because I'm working on something else over here, that they need to be engaging that person. And they take ownership and they take a stake in helping that person get better. Every single person that comes into contact with a patient, on the phone, on their way there, once they get there, while they're working with you, while they're leaving, during the follow-up, is part of that care. And that affects the experience, right? That affects somebody's perception of how their care is going. So, Sandy Hilton, you gotta make pain science the air that you breathe. You gotta it's gotta be everything. It's gotta influence every single decision that happens, every single conversation that occurs within your clinic, right? So you just gotta be breathing that pain science stuff in, because pain science is literally nothing more than the study of the experience of pain and everything that we learn about that and how we could possibly have a positive influence on that. So I got a couple minutes, and let's summarize. Let's talk about take-home points. Never, ever forget the pessimistic meta-induction of pain science. This is a brilliant conference, but I would be really disappointed if I show up here in 10 years and this same presentation is happening. Okay? That means we should always be open to moving with the evidence and recognize that what we know right now is incomplete and it is wrong, and we're just working on getting less wrong. And I have to think about that because I need to keep myself humble. Maybe our consciousness functions by making predictions about reality, right? Maybe these predictions appear to be based on priors paired with sensory information, and they're influenced by an embodied agent embedded in a culture, right? So I'm trying to bring in all this biopsychosocial, all this inactivism, all of this predictive processing into one kind of hodgepodge of ideas. And, we're probably never going to have a grand unifying theory that makes sense of everything, but I think that for the context and the situation, you can use these ideas to help you wrap your head around things from situation to situation. So remember that patients are masters of their experiences and that you must believe them. Always believe them. They're not pulling the wool over your eyes just because you don't understand their experience, because it doesn't make sense with what you know at this point. Because context influences perceptions and experiences, we have a role to play as contextual architects. We should feel the ownership of trying to set up an entire care experience in the most positive way that we can, in the most appropriate way to encourage progress and healing. The words that we say and the interactions we create influence expectations and subsequently other people's experiences. The more positively we influence that context and the more helpful cues we give, the greater chance we can help a person. If we reduce fear, if we empower people, if we facilitate the increase in somebody's self-efficacy and internal locus of control, we may just be able to reduce disability, to improve function, to positively affect somebody's quality of life, and maybe even influence pain. And I purposefully put pain at the end of that because I think that it's the least likely to directly be impacted, and oftentimes not what actually brings a person in. Oftentimes it's their disability. It's their loss of their sense of self. It's the feeling that they don't have control over what's going on in their life. So we should choose to be interactors versus operating upon somebody. So that's the second time this has been referenced, Diane Jacobs and Jason Silvernail. Just one of the most powerful editorials I've ever read that changed my perspectives on how to go about patient care. 100%. And last but not least, be a hope dealer, don't be a guru healer. So become a purposeful contextual architect. I got 26 seconds left. So what would you like to see me do? A cart. How did he do this? How did he do this? He was just like, and then.
Thank you, Jarod. There aren't tons of questions, so if you have questions, please put them in.
You don't have to ask questions.
Oh yeah, otherwise I'll ask them all. Just saying. Okay, so let's see here, we'll do this right. From Liz Pepin, could you further define, nope, that's from this lecture. I was like, oh crud, maybe that was an earlier one. We're gonna ask you a question from someone else's lecture. Could you further define embodied and embedded person?
I'm going to do my best with the limited scope of knowledge that I have, but I'm probably going to bastardize it if I'm being honest. But to claim that the idea of embodiment is to have the perception or the thought process that consciousness does not arise specifically just from the brain, but it arises from the interplay between the human mind and the body, and that you can't separate those two. So a consciousness is always embodied and receiving information and existing, generating consciousness through your physical embodiment, right? So we don't want to fall into Cartesian dualism. And some people criticize the predictive processing model because it's a little bit like the ghost in the machine, where you're just walking around, you have this brain that's existing within a meat suit that's predicting your reality. Does that help at all? Okay. Does anybody have anything to add to that? Okay.
All right. We have a question from Alice Sanvito. You raised the question of whether pain is always generated as a response to perceived threat. Can you discuss that?
I have no idea. I think that the threat perception model is probably the most popular model in current, pain science culture, because it's something that really eloquent speakers who are highly intelligent and have done a lot of research on the topic often refer to. But I've thought about it long and hard, and I have no idea where I stand. I think that it's a model that's probably wrong, but at current, it's maybe somewhat useful, kind of like the George Box quote. Because I think there are probably lots of scenarios where we could collectively come up with examples where people don't appear to be perceiving threat, but they experience pain. But then the flip side of that argument is, who are we to define what threat is on either a subconscious, conscious, or sensory level? So I don't think that we really have the capacity to answer that question yet.
Okay, I feel terrible because she told me how to say her name, and I got it like on the 47th try, but I don't remember how to say it correctly. Can you tell me? Shauka. Close? Thank you. Asks, do you know of any literature about the waiting room and decor?
So I feel like I've read something, but we know how that goes, and I bet that Jerry Durham does. I bet money.
Velocity's expectations research talks about the waiting room before.
I know that there is one study published, and I can't think of the author off the top of my head right now, but it was introduced to me by Adrian Lowe, that shows that waiting for longer than like 3 to 5 minutes in the waiting room once a patient arrives for their scheduled visit often leads to reduced outcomes from that visit and a lesser experience. But I have no idea the author there, so I don't want to misquote too much.
I don't mean to sound like a mom or a teacher, but hey, Jerry, you know how to use the app? Could you just toss that reference up there for us? Thanks, dude.
Yes.
Okay. I'm learning how to delegate on a more regular basis.
I like it.
So,
I like it.
thanks for the info. Also give it to me in writing. Okay. Now we have a question from Jason Erickson. If pain science is the air we breathe, what would you consider the food we eat?
This is tough. Yeah, I don't know. For me, it would be sushi. Absolutely sushi. That's definitely. That's what it is.
Even in Texas, I feel like that's.
Oh yeah.
I don't know.
There's overnight flights that like get that stuff in quick, but not as good as here.
I was gonna say.
Yeah.
Okay. Alrighty. Now we have a question from Edison Andres Longrano. Am I getting that right? Yeah, okay. Excellent. Fabulous. Okay. Do you think that there is a reason why many patients go to a guru? Why do the contexts handle the treatment very well?
So I think that people go to gurus because we have used a system that has pretty much told people that they are broken, they need to be fixed, and there's often gurus who, from a cultural and societal perspective, really push the idea that they have the ability to fix you. And whether it is a true belief that they have within themselves that drives them, or it's a malicious belief that they want to make money, or it's a malicious marketing tactic, you would never know what somebody's implicit drives and biases are. But I think that the cultural perspective through the traditional biomedical model and the traditional training, the traditional training approaches that we have had, that again Eric talked about last night, about the hyperspecificity of our ability to feel and do things with our interventions, probably drives that. So it's embedded in culture, and that embedded idea probably facilitates people to seek out a guru fix, because people are in pain and they're reaching out for somebody to help them, and they hear somebody say that they can help them, whether or not that's accurate.
All right, anyone else going to pop in a question, or should I do one? Okay, so a general theme for this weekend has been practitioners not validating patients, not really getting the top down, definitely kind of focusing on the top up. So this room, a room full of brilliant people, going back and making differences. Obviously, there's a lot of people not in this room. It'd be a lot more crowded. Where would you say we need to start to implement these discussions and thoughts and philosophies to have a larger impact on, well, mostly just how people are feeling? Because I don't know that it necessarily lies just in the healthcare system. What do you think?
So I hope you guys have a lot of time, because this could be an
You have 4
entire
minutes.
weekend. this could be an entire weekend course in and of itself, right? So yeah, we are, I don't know, like 100 people in a room when there's 200,000 physios in the United States, and that's not counting chiropractors and occupational therapists and massage therapists, personal trainers and medical doctors and so on and so forth. And Melissa, I know that you're not a physio, so I want to make sure I distinguish you, yeah, because I said all physios. We're just a drop in the bucket, and we're probably not going to affect real change unless, first of all, every single one of us are screaming at the top of our lungs and at the middle of our lungs and whispering and speaking to people in every possible way that we can. So, for example, I think the communication styles need to vary so we hit a large target of people both within the healthcare system and outside of the healthcare systems so we can get that snowball rolling. And some of those examples could be brilliant guys like Adam Meekins, who has a very strong and aggressive style, versus Zach Gabor with the Level Up Initiative, who's really trying to come at it from a less aggressive and more open, sit-down conversational approach, grabbing young clinicians when they come out of school and changing their biases as well, trying to get to the policy level where we actually change what the school requirements for education are. We start implementing the IASP curriculum for pain. We start going to legislators and actually educating legislators on this situation, because I bet every legislator that you go talk to at a state and national level either has had pain, had chronic pain, has a family member who has chronic pain, has somebody that's addicted to opioids, knows somebody that's overdosed on opioids. You know, you saw every single hand that came up in here when Marcos talked yesterday about the opioid situation. So if we're not hitting this grassroots from the bottom, if we're not going at the legislative level, if we're not going to the institutional and educational level, it's going to be a really, really slow process. And there is a quote that says change happens one death or retirement at a time, right? So some of it is, just a gradual evolution over time of old school beliefs and people that don't really have the emphasis or the care to be invested at the end of their careers to make those changes, and oftentimes they're in teaching positions and all that sort of stuff. Obviously not anybody in this room, but I think that we could dissect this problem down to just incredibly small little categories that we could affect change on people.
Awesome. We had a couple more come in. Do you want to do a couple more?
Oh, sure. Yeah.
Because I lied. You were actually had like 8 minutes. So, all right. So from Kirby, I didn't really mean to lie. I was just bad at math. Okay. So from Kirby Bohan, Kirby. Following on Sarah's question, how do we break the pattern of people seeing the guru healer versus the hope dealer?
Yeah, that's really hard as well. And I don't know if there's any one way to do this. In fact, I know that there's not one way to do this. There's not any single answer. But if we start changing society, if we start changing the messages that are on the television, the messages that are on the radio, the way that people are trained and educated, the laws that are in place, all of this sort of stuff, hopefully some of these ideas die out. Like who right now thinks that pain comes from a disruption in the four humors in the body? But that was the prevailing idea of pain for almost 2,000 years from Hippocrates, right? Well, actually, Hippocrates took it from one other guy, but he refined it. And it's like, oh man, you got imbalance of biles, black bile, red bile, blood, phlegm, this sort of stuff. That's what causes pain. But literally nobody in this room thinks that right now. And probably very, very few people in the country, or maybe even in the world, think that. And what we have to do is really try to take the ideas that we have right now, and we have technology, and we have social media, and we have the ability to disseminate information way faster. So hopefully it doesn't take 1,500 years to 2,000 years to change. We can be purposeful about doing that right now. And I think that everybody should be doing what I call peri-pain education. It's not what I call, I think I learned it from Mark Cardula, peri-pain education. Not only are you educating people in pain about pain, but you're educating everybody that you interact with about what we kind of know about pain, so that when they do have pain and they come to you to ask you questions, it's not It's not a totally new conversation because they've kind of been exposed to ideas and maybe that door is just a little bit cracked and they won't believe what the guru healer is saying to them as much because it doesn't make sense with what they've heard from other people that they respect a lot. Does that answer the question?
It's pretty good, I think. All right.
What's that?
You're very thorough.
Very
Oh,
thorough.
sorry.
That's good feedback.
Yeah.
That's good to get feedback. Okay, so thank you. You're good.
Thank you.
All right. Awesome. So not that there's really like a weak program to like to compare it to, but like we have a really strong finish as well. So we're going to start at 3:20 with Dave Walton. Again, I have not been asked to nor paid to say, but you can go get his book and have him sign it after his lecture. And then we're going to finish up at the end with actually a panel of fantastic speakers. So just see you back here at 3:20. And what? And the vendors. You have to go out these doors, go walk by the vendors. I said that at the last break, too.